Assalamu alaikum. Good afternoon, everybody. This is Najwa Adlan. I'll be the moderator of this session. On behalf of Saudi Society of Clinical Chemistry and SPOCTA, I'm glad to be the moderator, and I will introduce a very interesting two speakers. I hope we will have a good time. This is the fourth session of the series of point of care SPOCTA sessions. I just wanna remind the participant that in order for you to get the CME hours, please, when you receive the survey, put your CME hours so it will be entered under you. So you will receive a survey after this session. Please fill it in and put your CME so we can give you the CME hours for this session. Our first speaker is Mr. Tony Cambridge. Mr. Tony Cambridge is working in pathology management in a university hospital, Plymouth, NHS Trust, UK, as a lead biomedical scientist for over 20 years. He currently managing an automated chemistry, special investigation chemistry, POCT, and reception services of the blood sciences department. He have led his team through a huge service transformation since 2016, introducing a new managed service that changed all chemistry equipment, introduced a multidiscipline automated track system, and a new middleware. He have been recognized as a national and international speaker for conference speaking on POCT and pathology topics. Welcome, Mr. Tony, and I'm honored to introduce you.
Well, thank you for that introduction, and it's a real pleasure to be able to speak to the attendees today. I'm just going to start the presentation. Hopefully you can all see that screen. Now, we're going to cover a number of concepts around blood gas analysis today throughout the event. I'm going to start off with an overview of blood gas analysis. Now, blood gas analysis, in my opinion, is one of the backbones of the entire point of care service and cannot be done without in the modern healthcare kind of arena. So I'd like to advance on to the next slide and start to explore some of these ideas. Now, the acute care challenge that we all face at the moment is very much, an increase in acute care requirements of patients, not just in the large cities, but in very diverse sort of areas of all countries. And all I hear constantly is that we don't have enough critical care beds, we don't have enough assessment areas, we don't have enough emergency medicine resources available. What we need to do is provide those solutions that will help those services deal with the resources or deal with the patients within the resource envelope that they currently have. So patients in acute care settings require rapid assessment. This is where blood gas really comes into its own. And detection of rapid deterioration of the physiological state is one of the real beauties of point of care testing, where you have devices available to the clinicians, to the support healthcare workers, who can generate that diagnostic information in real time and make earlier diagnosis and take clinical decisions that improve patient management. So just an overview of University Hospitals Plymouth NHS Trust. We are a major trauma centre. Now, in the bottom left-hand corner, you will see a map of the southwest of England in the UK. The light blue circle is where Plymouth is, and you can see by the entire region, this is a peninsular network of 5 different hospitals. Some are district hospitals, some are major trauma centres, and some are acute care centres. Now, we have a unique geography, let's just call it. So as you can see, we are very coastal, and the distance between each of these hospitals is about 50 miles, I would say, from the furthest away to the nearest. You do have a concentration of hospitals in the southeast of this peninsula, with Plymouth, and then the two to the right, which is Torbay Hospital and also Exeter. But the landmass in the middle is very rural and mainly moorland. So we get problems with acute care resulting from endeavours around the coast and from people's activities across the general sort of landscape. Plus, it is quite a rural area with people living quite long distances away from their care settings. So we suffer from the geography. Our population is dispersed. Within the larger cities, we're probably talking 250,000 plus people, but then that's going down to smaller towns and villages. We do have a very convoluted way of obtaining funding within the NHS, and it can be difficult to resource our endeavours and our efforts and make service improvements that we want to in a timely fashion. Our hospital definitely has a capacity issue. So to give you a bit of context around that, we are currently operating at about 105% capacity in a 900 plus bed hospital, with queuing ambulances at our emergency medicine entry points into the hospital. And also, you know, due to the current global pandemic, we do have a major backlog in managing chronic conditions and also elective surgery. So we are also known as a prominent teaching hospital, and we're very well known for our medical research at this particular organization. So I'd like to start off by talking about point of care in general and the synergy between laboratory medicine and point of care testing. Now, laboratory medicine, as we know, has distinct advantages. So you have well-trained staff with degree backgrounds and really good history of training and development. You have very high-tech equipment with excellent IT infrastructure. The accuracy of these machines can't be called into question as long as you have a really decent governance structure around it. But point of care testing does have unique capabilities that the laboratory cannot rival in some cases. And in some of the cases with point of care testing, the analytes are not available within the laboratory, and we'll explore that a little later. The great thing about point of care is obviously, you know, it's nearer to the patient, it's accessible, and you need to have good governance structures around non-laboratory stuff using these piece of equipment, which I'll talk about more in my second presentation today. So there are some detractors of the use of point of care over laboratory tests. I would say that one solution does not entirely replace the other, but like I say, there is a synergy between the two solutions that in the modern healthcare setting, you know, you cannot now unravel one from the other. I think we're now in an era where we are heavily reliant on point of care testing, and one of those is blood gas analysis. Now, that's developed hugely since the 1950s to become an integral part of patient management. And the reason for that is a diverse number of tests that are available from blood gas analyzers, which some are calling acute care analyzers, and I tend to agree with them. Clinicians, however, need to be comfortable with the differences in results. Now, there will always be the argument about accuracy of results at the point of care. That sometimes comes down to device selection, the operator, but it also comes down to interpretation and how those particular results fit into any decision protocols and pathways that the patient may be put into and enter. So if we just look at the core tests that are available on blood gas analyzers, the test repertoire, you know, will cover the gases, you know, pH, PCO2 and PO2 with pH, electrolytes, metabolites, and as a co-oximeter on board, which will give you all the hemoglobin fractions, but also now we're seeing calculated bilirubin, we're seeing OD saturation, those sorts of measurements. On top of that, depending on your vendor model, you may see ionized magnesium, hematocrit, and you may also have calculated parameters, which if anybody is used to seeing a printout from a benchtop blood gas analyzer, there are many, but the ones that we tend to look at most are base excess, anion gap, and a GFR estimation. So where do we deploy blood gas analyzers? Well, everywhere is my answer. And the only place I haven't got on here, which is on the next slide, is respiratory, strangely. But if you look at where we are deploying blood gas analyzers, it is in intensive care, high dependency unit, all the emergency medicine areas. We're even contemplating putting blood gas analyzers into urgent treatment centers in the community, with projects underway at the moment, and also minor injury units, which are usually at community hospitals, to improve accessibility. But again, you need clinicians who are not used to acute care medicine being comfortable with those results and interpreting them and managing the patients. So we are covering acute care patients, mothers and baby in maternity theatres, central delivery suite where we would be concentrating on baby, and in NICU as well, where there are complications following birth, and in central delivery suite complications potentially during birth, where fetal scalp samples need to be analysed to assess the condition of the baby. And very importantly, as we'll come on to a bit later in this talk, so the surgical patient as well, specifically in the cardiac area, cardiothoracic operating theatre. So this is a nice table that just shows the breadth of deployment of blood gas, and it kind of rivals the usual kind of point of care devices that we've been used to for many years, decades even, in glucose monitors and urinalysis. Blood gas, glucose, ketone, urinalysis really are the backbone of anyone's point of care service, and then you'll see a deployment of other potentially handheld devices or small benchtop devices that fill out that repertoire of tests. But the important thing to realize is that we should only be putting point of care equipment into areas that will be making those rapid patient management decisions. It's not a luxury. Some of the tests can be expensive compared to the laboratory, but if you take a full appreciation of the downstream costs of care when you're just using the laboratory, it's sometimes more prudent to have that blood gas and other point of care analytes and results available to make those diagnostic decisions earlier to improve outcomes, because that is where the cost is really embedded in length of stay and deterioration of that physiological state. So let's talk about what blood gas really offers us. So it's primarily there to assess acidosis and alkalosis. So normal plasma pH is primarily maintained by several buffer systems within the human body. The bicarbonate system is the most important there. And plasma pH mainly depends on concentrations of bicarbonate and CO2. So if you have a loss of bicarbonate and an increase in CO2, that will lead to an acidotic state. And if you have an increase in bicarbonate and loss of CO2, that would cause alkalosis. And this can present in either a respiratory or a metabolic way. So most important applications. So hypoxia is one that's really at the top of the list. So this indicates tissue oxygenation, which can be very important. Well, it is very important to the physiological state of the patient. It guides ventilation requirements. It will give you an acid-base status, and also show you if there are any electrolyte imbalances that need to be corrected. But it's also very important in showing cardiogenic shock, cardiac arrhythmias, and the impact of CPR if it's being performed. Management of these strategies in life-threatening conditions rely solely on the rapid availability of the blood gas analyzers. So where these decisions need to be made, they have to have a standalone machine themselves with resilience, i.e. a second machine, instead of walking up and down corridors. Or if you still have blood gas analyzers in your department in the laboratory, which is something that we moved away from in the UK many years ago, then that will add inadequate sort of delays to the management of that patient. So let's talk about the operational benefits of the blood gas analyzers. Well, shorter door to clinical decision time, which we've touched upon. Rapid data availability, but this is very much dependent on your IT setup, what sort of level of connectivity you have, informatics solution, and also middleware that's in place. So all of our blood gas results enter the hospital network. So that moves away from anybody needing to be solely dependent on a printout from the machine. And you know that all of those results are then available in the network to be reviewed by any clinician in that patient's journey that will need to see, you know, what's being corrected and what the history of that patient's care has been. So reduced pre-analytical and post-analytical testing errors, which is very operator dependent. Some of the newer blood gas analyzers on the market are really intuitive in what they can do, which we'll touch on, I think, the next slide. And they're also becoming more and more user-friendly. So they're self-contained, very few consumables to change on some of the models, and some have full containment of everything you need to perform the analysis in one cartridge. The sample volumes are reducing with every generation of the blood gas analyzer models that are coming out, to the degree where you have flexibility of being able to change between modes, where you may even be able to go down to something as low as 50 microliters or thereabouts, all the way up to a full parameter list around 100 plus microliters. And when you have a patient, you want to be able to do serial whole blood measurements with no pre-analytical preparation. So you don't want to be taking too much blood for the laboratory unnecessarily and sending that off for centrifugation to get your electrolytes, for instance, or taking multiple tubes to get full blood counts, just to get a total HB, for instance. So this gives you a lot of flexibility around how you approach managing the patient, how much blood you're taking, how many times you are in effect assaulting the patient to obtain the material to run those tests. And if your clinicians have portable devices such as tablets or laptops, and they're connected up to the hospital network, they can access those those results at the bedside. Or if you have the monitors at the bedside or in the bays or the recovery areas, it can show you the patient's results in real time. So let's talk about the improved features that we're seeing on blood gas analyzers now. So they're very intuitive. So there's a user interface and software on board that prompts the user to, really perform the tests at the highest level of quality. There's even tutorials on board to show patients how to take the blood, how to analyze the blood, how to change consumables, maybe even how to look into the software to obtain the information that they're looking for. And one of the vast improvements over probably the last 5 to 10 years has been detection of interfering substances. Benzalkonium is one of those, but there are a number of others that can give you error patterns on the blood gas analyzer, which you can then choose to either not accept the results and have those held back on the analyzer, or to present them with a warning to the clinician to take a little bit of caution in interpretation. We're all being very used to detection of clots on these solutions, and the detection of inhomogeneous samples. So that's lack of mixing of the sample before analysis. Now this gives us a lot of power in trying to find out whether or not particular users do not follow the pre-analytical methods that we have taught them in their initial training, and that can target your refresh training to try and minimize clot and inhomogeneous samples. The full connectivity, if you do have the middleware connecting all of your analyzers together, allows you to take advantage of those remote functions. So you'll have remote connection to the analyzers, and that'll be able enable you, if you don't have a 24-hour system like most of us don't, to target where you go in the mornings. And there may be an analyze down, for instance, have an analyte out through a calibration error, and you'll be able to target your resources to go to those machines first. Previous to having full connectivity, you may have walked around your organization finding errors as you went, or just relying on the users feeding back to you that they had a problem with their machine. So this does focus your efforts. We now are very used to automated quality control programs and calibration. So again, this allows for periodic quality control throughout a 24-hour period, and corrective actions are built into that in terms of flush cycles and trying to correct calibration errors so that you can get maximum uptime from your machine. And of course, improve infection control. So if we talk about many years ago, we used to have injection into the machines from a particular sampler. We don't do that anymore. We have probes that now enter the barrel of the sampler itself, and there are other mechanisms and solutions to allow the user to automatically mix the sampler, for instance, depending on which vendor you're with, and also to basically assign barcoded samplers to particular patients so you don't get sample mix-up. But generally, waste is now contained on board and very easy to be disposed of. So I posed a few questions to the ICU clinical director about the effectiveness really of blood gas analysis in that healthcare setting. And I asked specifically, how does point of care blood gas help with managing the critically ill patient? So does it speed up recovery? Emphatically, it was yes, it can have this impact on patients. Does it inform changes in the patient management? Yes. Shorten length of stay. Now, I was talking about length of stay in the ICU here, and that was what was confirmed. Yes, we can make sure that patients are moving out of ICU a lot quicker, so that frees up the specialized bed for the next incoming patient, and move that person to less specialized area care where they don't need quite intensive management. So does blood gas and a good governance structure around it and a point of care team that's very active, does that assure the optimized care for patients? The answer was without a doubt. And have we affected mortality rates? And he found it difficult to actually assign this directly to blood gas or point of care, but it seems to be one element of improvements in patient care that has had this outcome. So examples of reliance on point of care testing blood gas results. So I just want to cover more than just the gases here and show you where the utility of using blood gases has become part of our everyday healthcare delivery. So if we start off with acid-base balance, so we assess this through measurement of pH and base excess, and these tests are not offered in the laboratory unless you have a blood gas machine. Metabolic alkalosis defined as pH greater than 7.45 with a base excess of greater than 5 millimoles per liter. Metabolic acidosis with pH less than 7.35 and base excess of less than -5. And then we've got severe metabolic acidosis with pH less than 7.2 with a base excess of less than -10 millimoles per liter. Now, there has been some conjecture around how accurate pH measurements are below 7.2, but having spoken to some of the ICU people who interpret these results, they don't mind if it's pH of 6.3, 6.4, 6.5, 6.6. What they want to see is a progressive improvement up to those levels where they know that blood gases can accurately detect. And respiratory acidosis, PCO2 greater than 7 millimeters of mercury with pH less than 7.25. So regular blood gas measurements support the correction of all these imbalances. And if we couldn't do them regularly, then I'd be waiting for the laboratory results to come back. So we also use blood gases to measure and manage pulmonary function. So this is essential, especially when your patient is on respiratory ward. Maybe they've moved there from intensive care or from emergency medicine, and it allows them, if they're ventilated, to make decisions around the adjustments required to improve that physiological state. And it also gives us opportunity to initiate early goal-directed therapy in patients with sepsis. Now, we all know sepsis is a massive the cause of death in acute care and outside of acute care, but also sepsis leads to poorer outcomes in almost every patient that develops it. So getting on top of that very early in the patient management and having those indicators through blood gas analyzers and the breadth of the analytes available is really key to the outcomes for that patient. We've also got continuous renal replacement therapy. Now, we've seen that in intensive care and acute kidney injury, that typically increases mortality to between 50 and 80% in that subset of patients. And the kidney is unable to excrete waste and maintain fluid, electrolyte, and acid-base balance. So the most common means really of managing acute or chronic renal failure in intensive care is with CIRT. We also have to look at the management of calcium and how important that is, because ionized calcium is not offered in the laboratory. We look at bound calcium, and ionized calcium can be very important with a target range of 1.12 to 1.20 millimoles per litre. And within an hour of commencing treatment, patient systemic ionized calcium needs to be checked through an arterial blood gas sample to make sure we're at the optimal level. Low levels need to be supplemented, which we'll see on the next slide. So we're looking for the red box. That is our optimal, which indicates 6-hourly testing because the levels are being managed well. But if you drop below 1.01, then you are in the realms of testing more frequently and trying to correct that imbalance, which is not good for your resources and certainly not good for the outcome of the patient. So we are looking for that optimal level, and we can only do that by having rapid measurement of ionized calcium on those arterial samples. We also look at monitoring citrate anticoagulation. So anticoagulation of the CRRT circuit is directed by the pulse filter ionized calcium, and again, those levels are extremely low. But if you can hit this sweet spot of 0.20 to 0.24, again, you'll only be indicating measurements at 6 hours. But if that post filter ionized calcium can't be maintained and drops below 0.20, then you are looking at 1-hourly management again. So this is poorer for the patient and more intensive for the resources and the staff that are working on that patient. And of course, electrolytes are very much part and parcel of blood gas analyzers, hence calling them acute care analyzers, because it goes beyond the blood gases. So severe hyponatremia is quite common. And if you are waiting for results to come back from the medical laboratory, that could delay changes in sodium supplements. So if you look in the diagram, rapid onset of acute hyponatremia and also rapid correction of chronic hyponatremia can lead to rapid increases in plasma sodium concentration, which in turn can lead to osmotic demyelination. And on the other side of that, rapid onset of acute hyponatremia and rapid correction of chronic hypernatremia can lead to a rapid decrease in plasma sodium concentrations, and that can lead to cerebral edema. So generally, there is a protocol that states that you shouldn't correct sodium levels by any more than 8 to 10 millimoles per litre over 24 hours. And again, this continuous monitoring using blood gas analyzers allows those step-by-step increments to be met in changing the sodium concentrations in any patient. Just wanted to put this table in, which shows the different solutions or the concentrations that need to be made up to progressively change the sodium concentration over time. And you can see in the third column with the sodium in millimoles per litre is shown there. You want to move a patient from the lower 120s and below up towards somewhere that is more reflective of the normal physiological state, 133 plus. So this table helps the support staff and the clinicians manage that improvement in the patient's physiological state, but it does require more intervention. So again, being able to manage that patient more frequently and not make large changes with an increased interval is very important. So I spoke to the cardiothoracic surgeons and the anaesthetists to ask their perspective, and they came back talking about bypass. So before they go into any cardiac bypass procedures, they want to correct any pronounced imbalances before the procedure. number one, but sometimes, their hand is forced and they have to go ahead with procedures, even though there may be some additional risk. So using blood gas measurements throughout will allow them to look at the base excess and the changes, depending on the interventions they're making, and that will indicate the adequacy of oxygenation in the blood. Historically, they've been waiting maybe 30 minutes for lab-based blood gases where they were available to come back. Now we provide at least 3 blood gas analyzers in perfusion so that they can make real-time assessments, and there's always at least 2 of those 3 available at any one time. And this informs changes in cardiac output while the patient is on bypass. So you imagine the patient is on the in the operating theatre. You don't want to be delaying any medical interventions that are required at any point. So we've constantly got runners going in and out of the theatres to access blood gas analyzers. So just a quick slide here to show the extracorporeal circuit. And we use the total HB to direct transfusion. Now, there were some papers many years ago that didn't support the use of blood gas analyzers in making transfusion decisions. Now, we've done some recent work to show that the accuracy of the co-oximeters on the blood gas analyzers now rival the handheld total HB meters or have improved quality and are in line with the laboratory measurements. So that is a route that we'll be taking from this point onwards. The specific questions they'll ask is the base deficit growing? Is the lactate level rising? And if so, they make correction on the perfusion interventions that they're making. So in terms of the way that we structure our blood gas service, there are undoubtedly new protocols in place that are developed over many years. They have been based around the improved accuracy and performance characteristics of the blood gas solutions that are on the market now. Decisions are now less subjective, so there's less interpretation to make, although that comes down to clinical knowledge and expertise. There's a more systemic approach to governing the services, better training and development of staff, and competency assessment, which we'll talk about in my second set of slides. And we're steadily seeing improved outcomes, which can be attributed to the availability of blood gases and the outcomes that we've seen with patients in certain subgroups. So the key learning points from this first talk: the use of blood gas analysis is integral to providing specialized patient care, and now we're moving that care out into more community settings to try and manage chronic conditions, maybe respiratory conditions, away from the hospital setting. These areas of care are highly dynamic, so need access to rapid diagnostic information, and trying to reduce the time taken to take interventions and make the right interventions is very much reliant on accuracy of results and availability of results. Point of care availability, depending on what your setup is in your own organizations, drives the protocols really. So, if you've got one analyzer available on a corridor and lots of acute areas accessing it, I'm not saying that is the case in the large, but that is down to maybe funding, maybe resource driven, and it will affect the protocols that are written around point of care use. Operators need devices that are easy to use, have detection systems for interferences and sample issues such as clots. Well, we're very used to that, but I think these next generation of point of care solutions are really intuitive, really give us information around the efficacy of the results that we're receiving, and get us to think just for a moment about the results that we're being presented and whether they are accurate or not. Results must have clear interpretation and meaning. So again, going back to some of the processes in place and the interpretations linked to protocols, it shouldn't be a guessing game as to which step to take next. And what we need to do is assure that we have analyzers available in multiple areas all at the same time with near to 100% uptime and resilience through either supporting through staffing to be able to fix analyzers, respond to downtime, or through having multiple devices required in each of those acute settings. And that will ensure that patients don't have to wait for that diagnostic information and the clinical decisions. Okay, that brings us to the end of this first set of slides. So thank you very much for your attention.
Thank you very much, Mr. Tony. It was a very nice presentation. Please, for the audience, please put your questions on the chat box, and we will have a session for question and answer by end of this session. I am glad now to introduce Ms. Elaf Al-Amoudi. Ms. Elaf is currently an acting point-of-care coordinator at King Faisal Specialist Hospital and Research Center, Jeddah. She obtained her degree in medical laboratory technology from King Abdulaziz University Hospital, Jeddah, and she's an ASCP certified in biochemistry. She participated in different conferences and seminars, regional and international. She completed ASCC certificate of POCT specialist program, and she has a 6 black belt and 6 Sigma and black belt. Welcome, Ms. Elaf.
Thank you very much, Ms. Najwa, for the introduction. Let me share the slide. Hello, everyone. Good day. It's Elaf Al-Amoudi. I am acting POCT coordinator at King Faisal Specialist Hospital and Research Center, Jeddah branch. Today, I'll be talking about the lactic acid or lactate, and we will be mentioning the lactic cycle, lactate normal range, causes of elevating lactate, Abg result interpretation on lactates, treatment, and finally, POCT role. Lactic cycle. Lactate is an organic molecule produced by most tissues in the human body, with the highest production found in muscles. And in general, lactic cycle is as the following. Lactate is generating from glycolysis in anaerobic condition. Anaerobic condition means this situation that you have not enough oxygen in your tissue, or there is no oxygen. And the cycle is very simple here. The glucose is converted to pyruvate by glycolysis, and pyruvate now will have two options. It depends on presence of oxygen. If there is a presence of oxygen, and thanks to pyruvate dehydrogenase enzyme and cofactor thymine, the pyruvate will convert to acetyl-CoA, entering the mitochondria with oxidative phosphorylation mechanism to produce as energy. And the absence of oxygen, pyruvate will convert into lactate. Having a large amount of lactate in our circulation is not good. Therefore, the lactate will go to be stored in the liver to form again glucose from gluconeogenesis. Next one is lactate normal range. There is no such low value of or low level of lactate, and the normal range in perfectly healthy patients is from 0.5 millimole per liter to 1 millimole per liter, and we can consider less than 2 millimole per liter in critically ill patients normal. Causes of elevating lactate. We have here some of causes that can cause lactate elevation. First one is anaerobic metabolism. As we mentioned earlier, this condition with no oxygen or no enough oxygen in the tissue. Example, excessive exercise or hypoxemia. I think most of us practice this condition with the exercise. When we go to the gym or do some exercises, at first the situation is fine since our source of energy is your oxygen inside your tissue. But after a period of time, and there is no enough oxygen, your body will go into anaerobic metabolism, and your all pyruvate will convert to lactate. And this is the reason why we have sore in our muscles. The next one is poor perfusion, such as shock. Next one, for sure, sepsis and infection. And lastly, organ failure, example renal or liver. As we know, our kidneys and our lungs play a very major role in our acid-base balance, and the effect in any function of any of those organs, renal or lungs, will affect our acid-base balance. Here, before we dive in more, let me explain briefly about what does ABG mean, and how do we know blood acidity and alkalinity in order to know the terminology of each condition when we encounter those or some of those terms later on in the lecture. ABG, it's the standards for arterial blood gas. It's basically the measurement of acidity or alkalinity of blood arterial circulation, and it's also measuring other parameters such as oxygen, carbon dioxide, coaximetry, lactate, glucose, electrolytes, etc. And the main three elements to help us decide the activity, acidity and alkalinity are pH, PCO2, and HCO3. pH is the measurement of how your blood acidic or alkalotic. Normal range, normal value for pH is from 7.35 to 7.45. And please remember this range because it will help us to remember the next normal range for PCO2. So PCO2 is basically the measurement of your carbon dioxide, and the normal range for PCO2 is from 35 to 45. It's easy to remember this range since the pH is 7.35 to 7.45. Just remove the 7 and the decimal and you'll get the normal range of PCO2. And please remember, CO2 is controlled by your lungs. Your lungs are breathing out your carbon dioxide, and carbon dioxide is directly proportional with the amount of hydrogen ion produced. So as high as we get for CO2, we have in return high acid. Next one is HCO3, is the measuring of our bicarbonate. The normal range for this is from 22 to 26. Bicarbonate is controlled by our kidneys. The more HCO3 in the blood, the more basic the blood is. And please remember that our lungs and kidneys meant to work hand to hand together to maintain the pH normal from 7.35 to 7.45. And ABG results interpretation. Here I want to mention also the PO2 or oxygen is also regulated by the lungs, but and the normal range is of the oxygen is from 80 to 100. And this range, it doesn't tell us the situation is respiratory or metabolic, and either our blood is acidic or alkalotic. It just tells us if the patient has hypoxemia or not. And to interpret ABG results, we have to identify three parameters. First of all, identifying if it's acidosis or alkalosis by looking at the pH. So if we have pH less than 7.35, which means it's acidosis. And if we have more than 7.45, it's representing the alkalosis. The next one is identify if respiratory or metabolic by looking at CO2 or HCO3 by concept method. As we know that CO2 is controlled by lungs and HCO3 controlled by kidneys. So CO2 is representing the respiratory situation and HCO3 representing the metabolic situation. So if we have PCO2 normal and HCO3 abnormal, this condition is metabolic. And if we have PCO2 abnormal and HCO3 normal, this condition is respiratory. The last one is identify if it's compensated or non-compensated. So let us take an example to make it clear to everyone. Here is the example. If we have pH 7.25 and PCO2 50 and HCO3 24. As we know that the normal range of pH is from 7.35 to 7.45, and this one is below the normal range which means pH is low. PCO2 here is 50, and the normal range is from 35 to 45. So that means PCO2 is elevating, and HCO3 is 24. That means, and the normal range of HCO3 from 22 to 26, and 24 is within the normal range, so the result here is normal. So we have pH low, which means acidic, PCO2 high, which represents a condition of respiratory. So the answer here is respiratory acidosis. This is the condition of this example. And now let's go back to lactate and how to do the interpretation for any blood gas results with high level of lactate. I've tried to make it a build-up structure with lactates, so we can, it will be easy to remember and hard to forget, and we will emphasize each letter as a reason of the elevating of lactate. We'll start with letter L, which is the liver. When we have any liver diseases, we have for sure elevating lactic acid because there is no lactic acid converted to glucose. Since the liver is not working and no gluconeogenesis performed, we can find it in chronic alcoholic patients and chronic liver diseases. The next one is accelerated glycolysis. Through fever and sepsis, hypothyroidism, or some of the drug effects, these are speeding up the mechanism and accelerating the glycolysis and can overwhelm the pyruvate dehydrogenase. So not all of the pyruvate will convert to acetyl-CoA. Some of them will convert to lactate and causing elevating lactate. And such other drugs that can affect the accelerated glycolysis, such as adrenaline, epinephrine, salbutamol. And here is an example of, I don't know if it's clear, but I will tell you the results here. So we have here elevating lactate with a treating patient with asthma. First picture on the left is the blood gas results for a patient with asthma before the treatment. And on the right is the results for the patient after the treatment. The first one, the pH was 7.25, which is low. PCO2 was 55.5, which is high. And lactate is quite elevating, it's 4. And after treating the asthma, pH in the other picture became normal, 7.36, and PCO2 is normal, 38.8, and lactate here is elevating. It was 4, and now it's 5.5. Here the asthma is fixed, but lactate is elevating. This lactate is not telling us the patient is sicker. This lactate telling us the patient has side effects of treatment. And the blood gas is telling you the patient actually is better, for sure, as well as the clinical assessment. Let's go back to our chart. The next one is congenital disorders, inborn errors of metabolism, which means that the mitochondria is not functioning very well. So pyruvate to acetyl-CoA entering the mitochondria, doing oxidative phosphorylation mechanism to produce energy is not going very well as long as the mitochondria are not functioning, which leads pyruvate to convert to lactate. So if we have a newborn with high lactate, we might consider congenital disorders. Next one, something also to bear in mind is thiamine, which is the cofactor in function of PDH, pyruvate dehydrogenase enzyme. So in case of thiamine deficiency, PDH won't work so well, which leads us to elevating lactate. Example, if you have a patient in ICU with very, very high lactate and the reason is thiamine deficiency, after the thiamine infusion, the lactate level for sure will be decreased. Next one is anaerobic metabolism, which means no oxygen in the tissue. We mentioned earlier this example, we mentioned the exercises and hypoxemia, but there is another example called ischemia, is a condition in which the blood flow or oxygen is restricted or damaged in part of the body. Example, if we have cardiac ischemia, is the name of decreased blood flow and oxygen in the heart muscles. Next one is toxic and drug effects. So some of drug effects, such as diabetic treatments, will inhibit the gluconeogenesis in the liver, which lead to elevate lactate. And some of toxic, if we are poisoning our mitochondria by carbon monoxide or cyanide, those are all cause elevating lactate. Next one is extracellular movement. Well, this one is interesting because it's combined with the condition with alkalosis, not acidosis. So if we have a patient in ER with hyperventilation and he has a high pH, this pH actually, it works as a factor of, as a transporter factor for lactate and make it move outside the cell to the circulation, causing increasing in lactate level in our circulation. And this elevating lactate is not the underlying causes, it's only the resulting of this condition, hyperventilation. Last one is sepsis. Sepsis, it can cause mitochondrial dysfunction, PDH dysfunction. Sepsis through fever and hypermetabolism function can lead to produce excessive amount of pyruvate and will convert to lactate. And since no enough oxygen in the tissue, patient might go under shock. So we can conclude that the mechanism of rising in sepsis is multifactorial and it's not solely. And let's talk about the treatment. The treatment of elevated lactate level should be determined by the underlying causes. For example, if we have hypoperfusion or hypoxemia situation, focus on improving perfusion to the affected tissues. And in case of shock, the treatments will include fluid administration and vasopressor. In ischemia, surgery may be needed to restore circulation or remove damaged tissue. Last thing here, I want to talk about the POCT role in lactate monitoring, or basically POCT means that point of care testing, that it's any lab test that can be done outside the lab or bedside by certified non-lab staff. And to be certified staff, you have to complete the competency. This competency assessment will contain the training, reading the manual and policy and procedures, and for sure passing the knowledge exam. We have two types of competency. We have initial and yearly. Initial is for the very first time staff doing the competency, and it is valid for 6 months. And after 6 months, the staff has to redo the competency to be valid for 1 year. And after that, only once a year he can redo the competency. And to maintain the lactate test and to give timely and accurate results, we have this test set in our hospital in blood gases machines. It's under point of care testing. It's distributed in critical areas beside the emergency. So we have blood gas in emergency. We have it in OR. We have it in cardiac intensive care unit, CSICU. We have it in medical intensive care unit, MSICU, and we have it in neonatal intensive care unit, NICU. And we have the RT team, respiratory therapist team, plays major role to maintain this service, and they are competent and well trained to do the troubleshooting and to do the proper maintenance to the machine. They are trained to run the patient samples and the external control, example, proficiency testing that we have periodically from our accreditation. Our lab is CAB accredited, College of American Pathologists. So, as a point of care coordinator, I overview remotely the quality control. I have to make sure that auto QC run every 8 hours and auto calibration runs every 30 minutes, 1 hour, and 2 hours. And to monitor any trend or shift in the levogenic chart to troubleshoot the QC and give good QC all the time. For sure, reviewing on a daily basis the patient results and the critical results must be informed to the encounter physician to do the proper intervention. We are doing all this to get positive patient experience and to give the highest care to our beloved patients. Well, that's all from my side. Thank you very much for listening. I hope it's informative, and thank you. We'll go back to Ms. Najwa.
Najwa, I think you're muted.
Thank you very much, Ms. Elaf. I was muted. I want to ask one question which was given by the audience related to your presentation. It's from Faiza Youssef. She asked, how about mixed acidosis, increased PCO2 and decreased HCO3? Elaf, are you still with us?
Yes, I'm with you. What is it again?
She's asking, how about mixed acidosis? How you interpret it, I think. How about mixed acidosis in elevated, sorry, I'll read it again. Elevated
CO2
and decreased HCO3.
This is in a situation of compensate or non-compensate. It depends on the pH. What is the pH value? If it's normal or increasing or decreasing. In this case, the pH should be low because she mentioned acidosis, is it?
Yes.
Am I right?
Yeah.
Okay. Now it depends of the value, how much PCO2 and how much HCO3. Because if we have acidic, which means low pH and high PCO2, so the bicarbonate should be it will compensate. It will be it will change the number, so it can go back. PCO2 will go back again to the normal level, and pH will be normal. So this will have, it could be respiratory acidosis, but it's still not fully compensated.
Okay, there is another question related to the compensation only. Could you please give us more explanation about the mechanism of compensation?
I was tend to explain more about compensation, but the thing is that I wanted to make it very simple, just to know the respiratory acidosis or respiratory alkalosis, the most common condition related to elevating lactate. And I didn't want to go out from the subject, but I can explain more about it next time, or if we have time by the end of the lecture.
Okay, thank you for that.
Thank you.
So thank you very much, Ms. Elaf. Now, can we get Mr. Tony again? Mr. Tony will introduce, will shed a light on the meeting accreditation standards for blood gas testing. So welcome again, Mr. Tony.
Thank you. Okay, so we're going to go into a bit more depth around the structures that need to be in place to assure that an organization and a service is ready for accreditation. Now, the learning points from this talk will be: why is accreditation important? What elements need to be in place? And how does this apply to blood gas analysis? Staying on the topic that we have today. My content is going to, or the themes at least, are going to be around quality, around competence, and around governance. So as a bit of an introduction, I should say, to accreditation standards, the standards are primarily set out to structure or sets out a structure for demonstrating safety, quality, and competence. Now we're going to explore those terms a little more in depth. And in terms of the standards themselves, such as International Standards Organization, ISO 15189-22870, which are the laboratory medicine and the point of care ISO standards, the interpretation of these can differ because the clauses described within the standards aren't self-explanatory. They do not tell you how to do something. They tell you what should be in place to provide evidence that you have good control over your processes. We'll explore that a little bit more in a moment, but accreditation bodies such as CAP and UCAS, they will be very supportive in preparing and maybe doing a pre-assessment before you go through an assessment, just to see what the status is of your governance structure and what evidence you're generating to really give them assurance that the quality of patient care is being optimized and it's being monitored. It's not actually mandatory, even in the UK, especially in the UK, but it should be aspirational for all. In the UK, I believe, because we are accredited to ISO through UCAS, the United Kingdom Accreditation Service, we only have about five or six organizations that currently have that status. So in terms of blood gas analysis, we've touched on a few of these threads in the initial talk and Ms. Elaf's talk that she just went through there. But, blood gas analysis gives us the opportunity for rapid testing. So therefore, those results are available very quickly. They are acted on immediately. And therefore, you need to have assurance and safeguarding around those test results to make sure that patient care is optimized, there is no risk in the interpretation of those results, and therefore the patient is getting the best care possible. Touched on this before about error detection. What you need to do within blood gas analysis is make sure that operators know what they're doing, that they are well trained, that there is a syllabus that they are all working to, there are standard operating procedures in place, quick guides, for instance, as well, and that there is a mechanism for assessing their competence and also their confidence in producing these results. This can be done through different documentation that you control through a quality management system. We use a piece of software called QPulse, which basically is a repository of all your documentation, which sets out your structure of governance, including your SOPs, standard operating procedures. And this allows you to review and update and keep current all the information within the documentation that's being accessed by the user. And also the analyzers now and the middleware that they connect up to a lot more geared up towards the governance side of things. So there are user reports that you can generate, which give you indications of the quality and the performance levels that are being achieved within that service. Which we'll explore again a little bit further into this talk. What we need to do is scope out and horizon scan what is available in terms of those solutions. We need to go for the most simplest solutions on the market with minimal operator intervention. Now, this became very, very important during COVID-19, where we didn't want our users interacting with the machines more than they had to, i.e. exposing them to health risks or infection risks just by using the devices. Even with touch screens, we had to put processes in place to wipe down those touch points and make sure that there were no contaminants available that might cause problems. The machines now offer comprehensive operator management linked to their training and their competency, so you can control who has access to the machines, who can generate those results and act on them. And what you need to do there is have a structure in place where you're monitoring the usage of the machines by operator. So you need an operator list. You need to know how often they're accessing the machine. If you're using barcodes to or passwords to access a machine, is that being used over a 24-hour period where you know a person is not working? And therefore that gives you focus on trying to take the risk away from untrained operators accessing the machine because they've been subjected to badge sharing, as we call it, or password sharing. We need oversight of the service. So this is where clinical governance comes into its own. And usually having oversight of the service is not just being present and being able to go and visit those areas and support the users. It is data driven, and therefore you can make quality improvements based on data that you can take out of the middleware. And you can also design key performance indicators and quality indicators, which we'll touch on later, so that you can be more effective in delivering that service and supporting your users. And you could also look at your resource allocation. What elements of the service require more of your resources? Is it the training? Because training and competency and confidence will stop you from generating errors in the long run, and therefore you're not using up your resources in trying to correct those errors or manage those errors through your quality management system. So some of the fundamentals. So two of the words that come up in at least the ISO standards are quality and competence. So what do those actually mean? And my interpretation is that a point of care service is delivered and needs to be delivered within a robust, well-designed quality system that service users are competent and they are able to deliver a safe clinical service. The challenge, therefore, is to set up that effective quality system and ensure that users are fully competent to deliver the principles of that system. Accreditation allows us to formulate that framework and gives us some guidance, although, like I said, doesn't tell you how to do it, and necessarily there are different ways of developing that quality system. But what it does do is drive us to think about how we can ensure accuracy of results and optimize patient care. Now, compliance with the clauses within the standards, if you can show through evidence that you are compliant, then that will give assurance that you have control of your processes. And one of the ways of assuring good control is to have a standardized approach to everything that you're doing, and then make sure that all of your users and all the stakeholders within your service are working towards that standardized system. So why do we look at accreditation as being important? Again, that standardized framework promotes highest of quality. Being assessed by an independent body can really give you a different perspective on the quality within your service. It can give you indications on how you can improve that quality. We are all invested in continuous service improvement, and that is what the accreditation cycle allows you to do, because it's not just, we should be looking at it as one assessment. We should be looking at it as a number of assessments that you either meet fully at the first assessment and then build on from that perspective, or your first assessment goes well and it allows you some breathing room to look at other elements of the service that may just need to be improved a little more. It promotes understanding of the concepts around quality and safety, and you should have a quality manager or a quality team to be able to back up your approach to delivering quality within the service. Now, that can be hard to come by because most of the quality teams and quality managers I've been working with are more geared up towards the medical laboratory rather than point of care. So again, they're getting used to these standards that are available within to be assessed against. We've talked about standardized patient care, but again, it's a culture of continuous improvement. And I think you need to get that message across to your users or the stakeholders about how important point of care testing is in delivery of healthcare and promoting the best outcome for the patients. And if you can get that culture right, and you can get people using the service to be fully aware of the standards that need to be met, then you are on the right track in terms of promoting that continuous quality development. And again, if you are accredited, that is a recognition of excellence, and accreditation, especially in the UK, is not gained by all. Although I know that lots of laboratories with point of care involvement will have, globally, will have CAP in terms of their accreditation status. So what does quality actually mean, and what does it mean to you? So is it just quality of results? Is it the quality of care? Is it meeting designed quality indicators? Is it having a robust service? What about cost efficiency and clinical effectiveness of the service? Well, for me, it should mean all of these, and it's wrapped up in that system that we've just talked about designing, and the challenge is to demonstrate them through robust evidence, which we'll come on to. So one way in which we monitor our performance and quality is through a monthly quality report. So this will be a standardized report, which will cover a number of different quality indicators. What are you measuring there? Is it the number of non-conformances that have been generated against your accepted standards? Is it the number of clinical incidents? Is it audit findings, negative, positive? You need to design those quality indicators to meet the challenges within your own service. There's no one size fits all, and there isn't a list of examples that can be easily shared. But for most, quality indicators would encompass the errors within the service itself. So blood gas analyzers are very good at generating error codes. So I think I touched on in my first presentation that if you have a particular operator who has rejected samples in a higher percentage than others, you can target training for that person. If you also have failures in your consumables, you can take that up with the suppliers and make change there, or consider moving to a different platform. These are the sorts of decisions that should be made from quality indicators. And then you can set your key performance indicators, and what will they mean to your service. So is performance for blood gas solely around uptime? It's probably a large part of it, but again, your key performance indicators will be how you're performing with quality control, external quality assurance or proficiency testing. Do you have enough people trained up in each of those specialties to be able to support the service? Are there any gaps? So there's a number of different things you can monitor to actually show that you are performing well as a service. Now, there is some debate around whether or not every single machine or analyzer needs to be enrolled in proficiency testing or external quality assurance. We tend to do a rotational performance of samples over the calendar year. Some of that is driven by cost, but others are to do with the platform we have and the way that it measures its internal quality controls and the solutions on board. That minimizes through us having confidence and assurance of the performance, minimizes the number of times you would have to do proficiency testing. This would be a clinically driven idea and concept and agreement with the point of care team and the stakeholders, and should be backed up by recording that decision within your quality management system, so that when assessors are looking at reasons why the decision has been taken not to enroll every single analyzer for every single analyte, you would have that minuted in meetings. You would have a decision that is made by a committee, and therefore is backed up with a good basis. So other things we would look at in the quality report would be internal quality control, whether there's any bias, whether there's any failures, any particular analytes that are being affected. And this can be by consumable lot number. So that might come down to manufacturing, storage, or shipping issue. And The other thing we look at with the consumables is batch acceptance and lot verification. So we all know that consumables will change. The performance of the from manufacturing to clinical use can change between batches and between lot numbers that are produced. So you have to have a system in place to verify that. That may just be through internal quality control and calibration, but you need to state that within your quality system, within those documents that support your decisions, that is your approach, and it should be based on good science with clinical backup. And measurement uncertainty, there's a number of different calculations you can use for that, but you need to communicate to your users what the uncertainty around every measurement that is made using blood gas analyzers. So if, for instance, sodium on a blood gas analyzer is reported as 140, is that actually 140, or is it 139 or 141 if you have a measurement uncertainty of 1 millimole, for instance? You need to be in your verification and validation of each of the analytes performed on the blood gas analyzers. You need to have assessed that, quantified it, and then communicated that to your users, because in my first talk I talked about interpretation of results, and the end clinician needs to know if that analyte doesn't perform as well as the main laboratory, or whether there is a constant bias, and that needs to be taken into the interpretation of the result and obviously the clinical decisions being made for that patient. So moving on to competence now, every single user that is signed off to use a blood gas analyzer, talking about the breadth of the analytes available, the multiple decisions that can be made, they must be competent and confident to be able to use that machine. The assessors will be looking for the following. So, is there an understanding on how to interpret results and what results are available? Can they troubleshoot the equipment? So you can take some of that out of the system by going for very intuitive systems with cartridge-based solutions or minimized consumables. Can they change the consumables? If they can't, why is that decision being made not to train staff and stakeholders to not manage their own analyzer? From my perspective, the end user wants to take ownership of the system. They want to know that this is their analyzer for their patients, and they should be allowed the opportunity to be supported in that fashion and be allowed to take full control over that element of the upkeep of the analyzer. And when we're talking about a 24-hour service, for instance, and weekends, you cannot necessarily afford the resource towards a 24-hour, 365 days a year service where the point of care team or anyone from clinical engineering or medical equipment management services are available to go and support downtime. Now, documentation availability. So one of the elements, and this is sometimes difficult to do unless you have a repository of information that is available to the end user, i.e. a website or a portal that they can access documentation. You need to make sure the assessors know that you have done everything you can to communicate the procedure and the learning materials, and you fed back on performance back to the user. They need all the equipment and tools made available to them so they can meet that standardized approach to operating that piece of equipment and that device. If not, you're going to have unwarranted variation in the approach to using the analyzers. You can have a variation in the accuracy and precision of results, and that will cause a ripple effect, and downstream you will see poorer patient outcomes. So everybody needs to be up to speed with the standardized approach to using these devices. So how have users been trained? So they must be trained by an appointed competent person, but how have they been deemed competent? So if you are using the vendors and the providers to do the initial training, they will come with a sign-off of competency because they are from the vendor, but you need to be asking questions and seeing whether or not they have gone through a training system and a training process that you feel is adequate for them to pass on to your users. Now, we use a cascade system, so we have some clinical educators who take on the role of passing on in certain specialties that training, and therefore periodically we call those clinical educators back in and we retrain them to the set standard at that point in time, and make sure that they are competent and confident to pass on that training, because you will get variation between different trainers who may skip stages in the syllabus. They may not deliver the emphasis in the right areas of that training, and therefore it may be ineffective, and you have to be seen to be supporting your end users in doing the best job that they can. And training and observed competence must be recorded and made available. So you can have e-learning, and that's fine with the knowledge around blood gases, but you have to observe their competence in operating the device. So there has to be that face-to-face interaction as well as e-learning. So as I said, virtual content is not enough on its own. You must have that face-to-face training, and there must be a written competency assessment, which can be available online, or we do a lot of classroom training for the competency assessment around the knowledge, and we tend to do that on an annual basis, depending on the complexity of the device that's being used. Certainly for blood gases, that is one that we absolutely have an annual competency assessment for. Any declaration of competence must be on official paperwork that is generated by the point of care team and ratified through the governance group, which I'll come on to the membership of in a moment. And then we need to back up that in a central database and have up-to-date records, not only kept locally with the individuals themselves, so they have a CPD record, continuous professional development record, which will show what training they've undertaken and what knowledge and skills they have, or they may have that electronically, depending on your organization's approach. And within you may have a training policy, for instance. Within your documentation, it will set out where the reassessment period lies for each device and which test. So that may be different for glucose monitoring, which is used on a daily basis throughout the day with pretty much all of the nursing team and the healthcare assistant team, whereas somebody who would be doing INR testing may do it in a clinic once every 2 weeks. So you have to define that period based on either the risk of the test and the device or the complexity. So in terms of the governance structure, in order to govern blood gas, that must be embedded into your governance reviews. Defined structure must be in place with effective leadership. So you need clinical input and you need oversight from management within pathology. And the structure must be well communicated. And you tend to do this through your point of care testing policy for the organization, and also in the terms of reference. So what is that policy aiming to do, and any committees that are brought together, what are their what's their remit? What are they trying to achieve in terms of their activities? And the function and the authority, that is a large part of governance, giving authority to the right people at the right levels in the right specialties, covering all elements of where blood gases are deployed is very, very key. So you may go to the head of nursing
Mr. Tony, we cannot hear your voice. Mr. Tony is connecting back on, so kindly be patient with us. Meanwhile, till Mr. Tony join again, I would like to mention again that people who are interested to get the CME hours, please, you will receive a survey in your email which you registered with. Answer this survey, and in the survey you will have to be put the CME, the Saudi Council hours, and the
Hi.
they will enter the hours again. Welcome back.
Apologies. I was automatically disconnected from the room for a moment, so thank you for your patience. Do you want me to continue?
Please go ahead.
Sure. So we cover the terms of reference. So I'm just going to move on from this slide, and we're just going to go over some governance essentials. Like I say, a point of care testing policy, which defines the roles, expectations, and the responsibilities of the service providers and the stakeholders within the service must be in place. And that needs to be ratified by a medical director of the organization. You then have the point of care management group. This is more of an operational group that deals with real-time issues and then meets monthly. We'll come on to the membership of that group in a moment. We've then got a point of care testing governance group, which meets on a quarterly basis, and that is where we escalate many of our issues from the management and operational team up to the governance group, where we can't affect positive change, or we need resources, or we need to adopt new solutions. We have clinical incident review, and that basically is a review of anything that has been generated in terms of an error, something that's affected the delivery of patient care, or we've had a negative outcome for patient care. And we will look for trends. We will look for areas of poor performance or negligence, and we will take action against that. And when we look at our governance structure in a moment, throughout our organization, we have access to higher levels of governance to take those actions forward. One thing that we shouldn't forget is service continuity plans. So to govern your service well, if things do go wrong, you have outage on an IT system, for instance, or your middleware, you should have a plan in place to be able to gather information around the quality and the performance within the service, either direct from the analyzers themselves or some sort of backup. But also, if key pieces of equipment are malfunctioning in certain specialties and you need a rapid turnaround on getting a replacement, then there should be those discussions put in place and a mechanism in place to work with the procurement teams and the vendors to provide those at very short notice. Now, throughout the COVID pandemic, there was a mad rush to get blood gas analyzers, because this is a respiratory infection and a respiratory condition that needed potential ventilation of patients. And we've talked about the utility of blood gases in managing those states. And literally, there was a shortage globally. That was from a manufacturing and also a logistical perspective. And within the UK, that was being centrally conducted in terms of who was getting which analyzers. But we did have some plans in place with vendors that we had contracts directly with that we were able to purchase outside of that allocation within the UK and keep our acute services going. Non-conformance. So we look at our non-conformances for root cause. So we want to see if there is a trend, what was the cause of this particular error, and we'll discuss those as a group, and we will determine whether those are one-offs, whether they're going to occur again, or whether there is a process or procedure that is generating that error. We will make those changes and agreements to change a process within our committee. And we would also look for the extent and impact. So if you do have a root cause generated, say training was the issue in delivering glucose testing on a particular ward. What's the extent and impact you would consider at that point? How many other wards are affected by that same training issue? You would then start to focus on how that training has been delivered and by whom, as I was saying earlier about clinical educators, making sure that they are competent and confident to deliver that training, and therefore you are dealing with the extent of that potential impact on your service just by identifying a problem in one specific area of your service. So always think of the global, the horizontal approach and see where that root cause and the error that has been generated, where that could replicate, and that is where you can take some preventive measures to stop that happening in other areas. We also have a very developed audit program. So we look at horizontal, vertical, and risk-based audits. And there's no value at all in going back and auditing the same thing time and time again, especially if you're not getting any non-conformances generated from that audit. So we on an annual basis design an audit calendar that looks at specific risks and covers the breadth of the service, and that gives you full assurance and will give any assessor assurance that you are considering new risks, and where you haven't found any non-conformance, you are not wasting time going back and re-auditing areas that haven't got significant issues. And as I said, under clinical incident review, escalation routes, we need to go to the highest level of governance in the organization to get action, especially when patient care is compromised or potential to compromise that patient care. So here's a slide showing the governance structure. So, our point of care team / management team, when you look at the clinical and managerial, higher level managerial input, we report to the point of care governance group. We also engage with the medical devices strategy group. You may have something similar in your organizations, which is a lot about horizon scanning and looking at where the opportunities are, maybe bidding for funding, those sorts of things. But when you do have errors within your service, you need a route of escalation. So here for us, it's the risk and incident team. They would ask us to conduct additional investigations, gather more information, and if it can be managed at that level, that's absolutely fine. If it is an additional risk, then this may actually go as far as the trust board, and then decisions will be made there. So in terms of governance structure, just a quick overview of the governance group membership. So we want all specialties represented. It doesn't always happen, I must admit, but in the terms of reference, we describe nursing and midwifery, someone from the training and education department, someone from our pharmacy, the procurement team, obviously the point of care testing team is represented there, and then we've got critical care, cardiothoracics, pediatrics, maternity, similar to where we looked at the blood gases being deployed earlier in one of my slides. If you don't have that cross-sectional and multidisciplinary engagement in your governance group, then you're effectively making decisions on behalf of stakeholders who have no appreciation of those decisions and why they're being taken. So it's best to get buy-in from the outset and getting somebody from each of those specialties to engage in the process, to attend the meetings, to review the minutes, to input into those decisions. And then you can say, this is a committed decision for the best outcome within our organization for patient care. Our point of care management group membership, again, just to describe our point of care team, we have one point of care coordinator on a full-time contract, and then we have a band 6 in the UK on our scales, a specialist biomedical scientist. We then have a team of associate practitioners who really go out there and do, really go back there and do the ward activities. So they'll be maintaining the equipment, troubleshooting, delivering the training, and then the biomedical scientist and point of care coordinator will be taking more of a governance approach. So they'll be looking at writing the documentation, for instance, working within a quality management system, reviewing incidents and risk. And then we've also got some administrative kind of roles. Our assistant technical officers may be doing more work back in the lab, especially with external quality assurance and proficiency testing, preparing those samples, sending them out to the wards, collating the results. And having this resource, it makes us more effective. And one of the examples I wanted to give you was proficiency testing. Without the number of staff we have in our team, we wouldn't be able to chase up the dates, the return dates that are associated with those particular schemes we're enrolled in. We regularly, every month, for every scheme that we're involved in, we see a 10% plus increase in the engagement with external quality assurance. So we set the bar relatively high at about 90% for most of our schemes, and we expect 90% of return rate. That would not be achievable because the first pass, you know, when you send out your proficiency quality assurance material, you normally get, or we do, around 70-75% come back. So we need that extra resource to go and chase up results, to take additional samples direct to the wards and the units and specialties for them to run on their devices. And that just gives you more assurance that quality is being maintained in those areas, even if it's not being done automatic. So, as I said, point of care management group in the box there. We meet monthly discussing operational and performance issues, and we'll only escalate issues to the point of care governance group where they would affect the whole service. So the learning points from this talk today. So we need to resource our service for success, and that's not just the people working in the point of care team. I've always taken an approach that our point of care team are the users of the service and the operators of our equipment as well. So look beyond your resources within that immediate team and see what other staff members across your organization can do to assist you in delivering the outputs that you need for that service. You need to set up an effective and efficient governance structure. That is a combination of documentation, the committees, and the decision makers, and being able to implement change. You need to measure your operational and quality indicators on a regular basis, and they need to be designed to make sure that there is a clear output. So, for instance, if you have the return rate for your proficiency testing below 80%, is that the trigger where you would then escalate that through the organization and say, we do have a quality assurance issue, people aren't engaging in the proficiency testing, therefore we can't be assured of the quality of the results that they're sending out. So it's managing that situation through having metrics that you can measure regularly and see a change. And if you're regularly reviewing, acting, learning and adapting, you will have either improved outcomes or no change at all, or things may even get worse. And you need to assess that to see how effective that change has been to make sure you made the right decisions. And we back up our evidence in our quality management system for review by any assessors, and to also document which decisions we have made. But we also hold an annual management review, which actually we're moving to quarterly now because we want to be more effective more regularly in making decisions on change. And you know, the outputs that come out of the annual or quarterly management reviews should be high level, so they should be achievable. There should be only maybe 2 or 3 objectives that come out of that management review, so it makes it achievable and has meaning around it. So that brings us to the end of the talk. Thank you for your attention. Draw your attention to the website at the bottom, which launched yesterday, which is a global resource for educational purposes around rapid testing, point of care, and anybody interested in decentralized diagnostics. Okay, thank you very much.
Thank you very much, Mr. Tony. It was a very nice and informative presentation. We're moving to the questions and answers. So, Ms. Ilaf, are you with us?
Yes.
Good. I'm inviting the audience to please put your questions on the chat board. We have few questions already. And I will start with the last one from Ms. Rosabelle Idralin, and it's related to the last part you talk about, Mr. Tony. Her question is POCT can be initiated by nursing administration if we are working in a small institution and institution only. So what is your answer for that? Mr. Tony?
Sorry, I'm here. Can you repeat the beginning of the question? It broke out.
She said she's asking if POCT, I think it's related to the
POCT,
governance. Yeah. Is POCT can be initiated by nursing administration if we're working in a small institution only?
Yeah, I mean, traditionally, the medical laboratory has been involved in the governance of POCT, but more and more we're seeing models where that responsibility and the ownership of the service isn't part of the medical laboratory. Yes, you need access to maybe the resources or equipment to do validations, verification, but there's nothing to say that as long as you have the correct defined responsibilities that are described within accreditation standards, if you have that defined in other specialties with appropriate levels of ownership and effectiveness in the delivery, that cannot be a model that works. So I'd be fully supportive of seeing that model move forward in the future.
Mm-hmm. Thank you. And Ms. Ilaf, what do you think about this question, knowing the Sabahi standard and CAP standard?
What is it again?
Can POCT be initiated by nursing administration?
I'm looking forward to know the answer. As far as I'm concerned, I haven't encountered this before.
Well, I would say, just add to that, sorry, that they need to still retain links to the medical laboratory, because most of the accreditation standards do mention the involvement of the lab. Certainly you'd need access to equipment to do verifications and validation where those analytes are available in the laboratory to see what the differences were. But in terms of taking a lead in the governance, then I think that nursing would be in a good position to take ownership of those services, which they are the main stakeholders for. You would need some clinical oversight, and you would need some organizational managerial oversight, but I think you could meet the standard for accreditation purposes.
Yes, totally.
I agree with that. Actually, Sabahi mandate that the ownership and the acquisition should be approved by the laboratory. So in part, yes, nursing administration can request and can have the ownership of having the devices or the testing. However, the lab should be involved in the monitoring and the approval and from all the accreditation perspective.
Yeah.
Am I correct?
Yeah, I would agree with that. Yeah, there's certainly some oversight. Yeah.
So Ms. Rosabelle also asked, is there a website wherein we can check for POCT competency or new updates?
I'm not aware of a defined website that would support sort of training and competency and learning other than the one I just described, but it's early days for that website. It's certainly something that is going to be on there in terms of guidance, but I don't think there's any website available at the moment with predetermined kind of competency assessments that you could access at this point in time, or training syllabi, but certainly in development.
Yeah. I think there is some manufacturer have a portfolio for competency for their own devices, I think, or softwares for that.
Yeah, definitely the vendor would be somebody to go to. I was kind of thinking of a repository of information that you would be able to access, but certainly for your own devices, your vendor should be supporting training and development and learning amongst your users. And what I would say is we wouldn't adopt 100% their competency assessments. We would develop those into our own and make sure that they met all of the accreditation standards and clauses that we needed to, because sometimes they look very glossy and very well designed, and then when you start to pick them apart, they don't actually cover the whole syllabus that you would like to for that test or for that device.
Ms. Ilaf, for your presentation, you have a question about how to interpret the ABG, and you give a lot of examples on how to interpret the ABG. But if you would like, or you, it's up to you if you want to leave it to different talk. If you want to talk more about the compensation, because there were a question about that.
Yeah, it's okay. I'll talk about it briefly. I hope it will answer the question. First of all, regarding the compensation, it's either if the condition is respiratory or metabolic. So if it's respiratory, we have defective in the range of the PCO2, so HCO3 will compensate. So if respiratory in acidic condition, the HCO3 results will see elevating in HC. So the result of HCO3 will be more than the higher limit of the normal range. For example, HCO3 is from 22 to 26. We can see here in compensated respiratory acidosis, HCO3 will be more than 26. And if the condition is respiratory alkalosis, the compensation here will be decreasing the level of HCO3, so thus decreasing the level of CO2. So in case of respiratory alkalosis, we can find results of HCO3 less than 22. So that can answer the question earlier, because she mentioned that if we have high CO2 and low HCO3, this is, and if pH is normal, this is fully compensation for respiratory alkalosis. But in the condition of metabolic, if it's acidosis, the issue here and the value of HCO3. So the CO2 will compensate. If it's metabolic acidosis, we can find results of CO2 decreasing less than the lower limit of CO2. So we can find level less than 35. And in metabolic alkalosis, HCO3 already high, and CO2 we can find it high as well, and more than the normal range, yani more than 45. Example, if we have pH 7.3, which is low, if we have CO2 50, and if we have HCO3 49, pH is low, and both of other parameters are high. But as I mentioned earlier in the lecture, in the presentation, that CO2 and pH are directly proportional. So we have a lot of CO2, which is 50. That means the condition here is respiratory, because pH is low and CO2 is very high, and HCO3 in order to compensate is high as well. So this condition is not fully compensated respiratory acidosis. That's all. I hope it answered the question.
Thank you. I hope they will benefit from it. I did. Thank you for that.
Thank you very much. Really appreciate it.
I don't see much question, but I have a question for Mr. Anthony. As part of the accreditation, when we have a new instrument of blood gas, we are required to do the validation, and you mentioned about the uncertainty, the exercises we do to make sure that the machine is accurate and fulfilling the requirement of the organization. Because of the difficulty in obtaining the material for the such validation, how is it validated? How that is being done, and also for the reference lab, for the reference range verification.
Have you currently got a blood gas solution in place which you're replacing?
Let us say that no, it's a new institution. Let us start from the beginning. It's a new institution.
Yeah. Because we rarely come across this unless it's a new hospital set up and don't have a reference lab to look at. But what I would say is there are quality materials out there, your proficiency samples that would cover the extremities of the reference ranges. What an assessment manager or an assessor would be looking for is that you've tried to verify the performance characteristics stated by the vendor for that particular piece of equipment. And if you didn't have another blood gas analyzer to compare it against, you have to go with the next best thing. Retrospective clinical audit or clinical audit whilst you're not using that blood gas analyzer in the service as part of that verification. So they can take the results that are being produced from that blood gas analyzer, and obviously they'll be taking decisions with those patients without those results being used clinically, but you can map the outcomes against what they would have done with the results that are coming out of that machine before you've actually put it into first clinical use. So there are different ways in which you can verify those performance characteristics, but it's by no means easy, and what you're doing is trying to minimize the risk as much as possible to clinical care in the long run. But yeah, if you're not comparing it directly with another known well-performing blood gas analyzer, it does become that more difficult.
So is it acceptable to start with like accuracy and start by precision and linearity check, and after that do the comparison or the accuracy check?
I think when you've designed your verification plan, you need to set out what your acceptance criteria is. That will be driven by your clinical leads, certainly is here. There are CLSI and other sources that you can go to which show you what to expect from blood gas and the analytes available on a blood gas machine. You may have to look at, there's another Canadian version, there's a Royal College of Pathologists. It's about taking that data and seeing what works for you from a clinical perspective and getting that sign off before you move forward with, putting your plan into action. But absolutely in your verification report, you got to say, where the deviations are, whether they're acceptable clinically. And again, that's where you need that clinical oversight to make those decisions as to whether that's acceptable within your service. So yeah, it's not an easy job with blood gases. It's not the same as, relatively straightforward analytes like glucose and INRs or total hemoglobin, which we have the laboratory to test against and compare against. It's not an easy undertaking, but it can be done through putting a network of approaches together in your verification plan.
Okay. And Ilaf, my question to you for the lactate. Is it, can we waive the reference range verification since the reference range is very low, like you said, 0.5 to 1? I mean, can we just follow the manufacturer recommendation without verifying it with normal people? Because it's hard to hire the clinically well volunteers to do that.
Usually for the calibration verification, we are relying on a survey from CAP called CVL. It's basically coming 2 times a year with all parameters of the blood gas that we're using. Lactate is one of them, and they have a different range of and levels from lactate, 5 levels each time. So we have 10 different values, and we run it twice a year, and we can get good reference range that can meet the AMR, the manufacturer range, not only the normal range. So that's what we are doing.
Verification of a normal range in the beginning. Do we have to do it in the traditional way, like what we do in the lab? Or we can waive it like when we waive the pediatric sample? Or
We are doing it usually, and it depends. We're not only for different type of samples, which is venous or artery or capillary. We are doing if it's not a normal range verification, we take the normal patient sample, and we see if it's meeting the normal range or not. After that, this is this is evidence for a normal range verification, and for the verification calibration, we are relying on CBL.
Okay. So we have a question here: difference between gap and non-anion gap metabolic acidosis.
This is
yeah. Go ahead.
Different topic. It's we can discuss it because it will take a lot of time from us. It's anion gap.
Yeah, I understand. So I have no further question. I would like to thank both of you. Actually, I benefited a lot from myself. I benefited a lot from this session. For the audience, thank you for joining us. People ask about the material. The material will be in the channel of Saudi Society of Clinical Chemistry on the YouTube channel, so you can review it there. For the CME, as I said, you will receive a survey. In the survey, you will put your CME, your Saudi Council number, and they will enter the CME. It's up to the Saudi Council to grant it or not grant it according to the approved targeted audience. Thank you very much.
Thank you.
I'm very pleased to.
Thanks for having me today.
Sure, it's been a pleasure. Thank you.
Thank you very much.